Hello everyone, my name is Katie Cutnall and I will be presenting on anencephaly with polydactyly. So for my patient, she was a 24-year-old Hispanic female. Based on her last menstrual period, she was 17 weeks and 2 days pregnant. The only pertinent lab values she had were that her HCG on the day that she came into the ER was 5.4. And then this was her 4th time being pregnant, and she had 2 living children. Here is figure 1 and figure 2 of the sonographic findings. In figure 1, you can see the grayscale image of the profile of baby. You can see one of the 2 orbits, and you can also tell that above the orbits there is not a cranial vault. You can see no head structures, and this is a sonographic finding of the anencephaly. And in figure 2, this is what they call a frog face. This is one of the telltale signs that there is anencephaly. So you just see the 2 eyes and there will be nothing above the eyes. In figure 3 and 4, we have more sonographic findings of anencephaly. In figure 3, this is another profile image showing, this is a really good image showing that there is no skull. You can see the little nose, and then above the nose there is no cranial structures. So that is again consistent with anencephaly. And then you have figure 4. This was another incidental finding of polydactyly. You can see that there is some extra toes. There's more than 5 toes on there. And this was a bilateral finding. So on both toes, the baby had polydactyly. And so the last 2 images, I have figure 5 showing the report. The baby, even though they did not have any cranial structures, the brain was absent, and then polydactyly, even though they had these findings, they were still measuring up to the gestational age. So they were still growing consistent with gestational age, and then they also had a normal and healthy heart rate for the gestational age. So the diagnosis of this baby is anencephaly with polydactyly. And I'm not going to go too much into polydactyly just because I did kind of describe what it was in that last slide. Polydactyly is any extra fingers or toes. In this case, the baby had more than 5 toes on both feet. So that's basically the definition of that. And then anencephaly is no cranial vault or brain tissue visible. So sonographically, you will not see any brain tissue, but whenever the baby is born, you might see a little bit of brain tissue. So this is the most common neural tube abnormality. This occurs whenever the neural tube does not close. So whenever the neural tube closes, that is whenever it would form the brain and spinal cord. So the brain is a major function of living and thriving. So this baby will not be able to thrive after birth. If these babies do make it past delivery, they will only live a few hours or maybe a day. I read that there is not a clear pattern of who is affected by anencephaly. What I saw is that if you have one baby that's affected by anencephaly, the next time that you become pregnant, you are not likely to have another baby with anencephaly. So it's kind of a sporadic pattern of who is affected and who is not affected, but it is caused by multiple genes and genetic and environmental causes. I also saw that in order to prevent anencephaly, folic acid has been proven to prevent anencephaly if you take it early in the pregnancy. So anencephaly does not usually occur on its own. It is usually associated with spina bifida or other spinal abnormalities, GI and skeletal abnormalities. They described clubbed feet or clubbed hands. And this baby did not have any of those. We saw that the baby had polydactyly, which is one of the skeletal abnormalities that is not commonly associated with anencephaly. So if you do see a baby with anencephaly, make sure you are looking at other abnormalities. Check the spine, check the extremities, check all of the other skeletal abnormalities just to make sure that nothing else is wrong. There isn't really any other modalities that are used besides a 3D ultrasound to get a good look at what this baby's face is going to look at. You want to be able to prepare the mother or the parents how this baby is going to look whenever they are delivered. A lot of these parents will have to have counseling, and you want to make sure that they understand that this baby is not going to survive very long after birth. So it is important that they receive proper counseling and make sure that they really understand that you'll only have a few hours, maybe a day with this baby, and just try to make sure that they understand that and are not in denial. Just make sure that they really understand what this baby is gonna go through. And now we'll talk about some risk factors. So maternal diabetes, obesity, and exposure to high heat in the early pregnancy is what can cause anencephaly. I saw a couple of sources say that the exposure to high heat can cause anencephaly. It didn't really explain why, but that was one of the risk factors that they talked about. And now we're going to go on to the differential. The differential that I chose is alobar hollow prosencephaly. This is the most severe form of hollow prosencephaly out of the 3 types. This is the abnormality where the forebrain is fused. So this will cause a enlarged single ventricle. It'll kind of look like a U shape. So it is fused in the front and then it will separate in the hindbrain. And then this is going to take up a majority of the brain tissue, and this will also cause facial abnormalities such as hypotelarism, cleft lip and cleft palate, cyclopia, and proboscis. And just like with anencephaly, a lobar hollow prosencephaly, these babies do not have a good chance of surviving if they do make it to birth. If after they are delivered, what I've read is that they only make it up to 6 months. So these patients are recommended to have the 3D ultrasound, just like with anencephaly, to prepare them for what this baby is going to look like. They may look abnormal because they have the cyclopia, or their eyes may be a little bit closer together. That's with the hypotelarism. And then they might have proboscis, where they have that extra tissue and it kind of just hangs off their nose like almost like an elephant trunk. And the parents are also recommended to receive counseling because, once again, these babies are not going to make it long after birth. So it's best to get in their brain early on that these babies are not going to make it, and just prepare them for, the consequences of this unfortunate anomaly. And now we will go back to anencephaly with my patient. So my patient decided to have a normal delivery where she will carry the baby up to full term, and she did agree to doing an emergency C-section if they were monitoring the baby and they had non-reassuring heart tones. So some patients will decide that they do not want to keep the baby up until delivery once they find out that this baby has anencephaly and are told that they are not gonna, live very long after delivery. So they may decide to terminate the pregnancy. Some patients cannot handle delivering this baby and holding it, and then the baby passes away soon after. Some patients just cannot handle that. So on February 28th, they did notice that the baby had non-reassuring heart tones, so they delivered the baby by emergency C-section, and upon delivery, the baby was still alive, so the mom took the baby to the recovery room and spent the last few hours with the baby, and they passed along shortly after birth. In conclusion, this was a 24-year-old female who presented to the ER with weakness. She had an ultrasound performed, which incidentally found polydactyly and anencephaly. The baby had no other abnormalities and measured up to the gestational age. The mother decided to carry the baby up until delivery and was delivered by emergency C-section because of non-reassuring heart tones. The baby shortly passed away after delivery. My takeaway message is that when evaluating a baby who you suspect has anencephaly, you need to fully evaluate the cranial structure, fully evaluate the extremities, and make sure that there are no other associated findings with anencephaly, because as we talked about, this is not an isolated finding. And my teachable moment is when you are faced with this situation, be very aware of your facial expressions. This is an emergency patient, and you find this anencephaly that is not a very common finding, not something you're going to see every day, and you just don't want to make the patient worry. You don't want it to show on your face that something is wrong with this baby. This is a very important part of our job where we do not let them worry. We don't want them to suspect that anything is wrong. And these are my references.